Good afternoon, everyone. Thanks for your time and your attention. As I said, I'm Ashley Morgan. I'm the director of the Substance Use Deflection Initiative, and we're part of NEOMED's Criminal Justice Coordinating Center of Excellence. So the Deflection Initiative's role is to provide coordination and technical assistance and other Center of Excellence functions that support deflection teams and harm reduction efforts around the state of Ohio. And these are teams you might have heard called quick response teams or post-overdose response teams. Today I'm going to talk about cross-sector coordination in deflection practice, and I'm going to draw on insights from our recent 2024 deflection inventory. So deflection bridges behavioral health and public safety, and it's really about meeting people who are using substances where they are, both literally in the community, it's very community-based, and figuratively from a stage of change perspective. And the goal is to offer them access to treatment and harm reduction and community supports as a pathway to care in lieu of arrest and incarceration. So if you're familiar with the sequential intercept model, deflection lives in that intercept 0 to 1 space. And individuals can be engaged using one or more of 6 pathways, which you can see over here. And I know this is probably pretty small, so I'm going to drop a link in the chat to the 6 pathways in case you are interested in learning more or you want to see. Oh, it didn't work. Hold on. I didn't get the whole link, it looks like. There we go. All right, but it basically shows the way that deflection can be initiated in a community. So you see self-referral on there. So for example, individuals can self-refer to a first responder agency that's participating in this to get connected to care or supports without the fear of legal consequence. The first example of this was the Angel Initiative in Gloucester, Massachusetts. Another way to get connected is a first responder might encounter someone on routine patrol or as a result of a call for service, and they might make a referral to a deflection team or to one of these supports that we're talking about rather than arrest. We also see teams that do active outreach. So they're proactively doing things like going to overdose hotspot areas or encampments to try to identify people in need and refer to services and supports. And if you're interested in learning more about these pathways, we do a deflection echo, and we're going to be taking a deeper dive into the 6 pathways in September and October. And I can share with you a little later how to get registered for that echo if you're interested. And there's also mental health deflection that's been around for much longer. You can see this with crisis intervention teams, for example. So in Ohio, we saw substance use deflection emerge a little over a decade ago with the first teams like Coleraine Township's quick response team in Hamilton County, Lucas County DART. And this was happening in response to the opioid epidemic and the surge of overdose deaths we were seeing in Ohio. But since then, it's grown really rapidly. And as I'm sure you all are aware, this epidemic isn't really just about one substance. And often the substance use is really a symptom of a root cause. So teams learned that and quickly adapted to what they were seeing on the ground and what their communities needed. And they adapted to the shifting drug supply and the landscape, and they continue to do so. So now we see teams including resources and making connections related to any type of substance, mental health supports, family supports. They're addressing social determinants of health. And many things just beyond just the overdose response. So the reason that we wanted to do an inventory in the first place is that this is a relatively new field, being 10 years old, and there's been a lot of growth and evolution. And we wanted to understand the landscape in Ohio so that we could start to explore what best practices will be for the field, as well as develop a roadmap for us as far as how to best meet team needs. So we interviewed 64 teams in 58 counties. You'll see on this map that we didn't catch everybody, but we made an earnest effort to. In green, you can see the counties where we did interviews with teams. Some of these counties had multiple teams. In blue are counties where we knew teams existed, but we weren't able to interview them within the project period. In gray, at the time we were doing interviews, these counties didn't have active teams. And then in white, we weren't able to confirm one way or the other. And just for transparency, pretty immediately after wrapping up our interviews last August, this map changed, meaning more teams have emerged over the last year. So the information in this presentation is coming directly from the information that we learned from the interviews of all of those teams. One of the first things that became obvious from the inventory is that Ohio's deflection landscape is incredibly diverse. And we had a sense that going in, there's like a saying in the field, if you've seen one quick response team, you've seen one quick response team. And this really turned out to be true. So we wanted to know, one of the things we wanted to know was who's leading the charge. And you see on here that leadership really spans across a lot of different sectors, with law enforcement and behavioral health led teams being the most common. But we also see fire and EMS led teams, public health led teams, healthcare leadership. And one of the things that's obvious when we're talking to teams is that if one of these entities is not a leader, the goal is to have a partnership. So, for example, if we have a law enforcement led team instead of a behavioral health led team, we still hope that there's a strong partnership and collaboration, or even a team member from that behavioral health space. So we learned about who was leading. We also wanted to know who was at the table, who's on the team. And on average, deflection teams include 3 to 5 different professional roles. Law enforcement officers are the most represented on teams, but that's closely followed by peer supporters and behavioral health providers. You can see that there's an other category on here, and we saw lots of other professions in there, including nurses, clergy, probation officers. So when you think about what systems, for example, peers or therapists can be embedded in, or what roles can be represented on the deflection team, the reach of the team can really broaden. And the coordination from that is then already present in the framework of the team. We also wanted to know who's reaching out, who's making referrals, who's coordinating from their sector with the team. And we saw that most of the referrals are coming from law enforcement or dispatch data, but here is where there's a real opportunity for growth. So if we think about all of the spaces where we might encounter someone with a substance use disorder, doctor's offices, OBGYN, schools, job and family services, if you had a deflection team that really specializes in this type of coordination that you can call on when someone who's at risk of a substance use crisis and might need connection, if you could call on that team, that might be a game changer in some of those spaces and for some of those people. We also wanted to know who the teams are making connections to. So what coordination is happening there? And you can imagine this as an extension of the continuum of care. So it starts outside the clinic, in the field, in someone's home, post-overdose, and then it connects into those therapy spaces, outpatient therapy treatment, MOUD, housing supports, primary care, dental care, etc. On this slide, you can see all the various ways that teams coordinate care to behavioral health treatment, medical treatment, recovery supports, basic needs, social supports. There's a lot of different spaces that they're touching. And there's a few key things that really allow this cross-sector coordination to flourish. And there are a few growth edges within the field. So when the referral network includes law enforcement, emergency departments, and fire and EMS, there's a much better chance to catch the individuals in need. And first responders can then be empowered to make referrals into healthcare systems rather than into criminal justice systems. Memorandums of understanding or business associate agreements allow for defined roles and responsibilities. So across the teams and the partnerships, it's really clear about who's doing what. And it also increases the chance that the partnership can weather things like a staffing turnover or a leadership change. Um, Interdisciplinary teams are important because they bring different roles, which brings different strengths and resources and connections. And as I mentioned before, the interdisciplinary aspect lays the foundation for that cross-sector coordination because of the roles that are present on the team or the agencies that are represented. And then having local champions, people with political or social capital that can advocate for, help get buy-in, build and sustain momentum for teams across multiple sectors. We saw this might be hospital leadership or a commissioner or a county board or a chief of police. Um, and the growth edges, privacy laws create barriers to communication amongst teams, or at least perceived barriers. Teams can get hung up on navigating HIPAA and 42 CFR Part 2. And in reality, it's not always the team members, the actual team members that are hung up, or those they're coordinating care with directly, but maybe the powers that be that are the roadblocks. Also, when we see a lack of infrastructure like policy and procedure or process, sometimes there can be instability if there's staff turnover, for example, or leadership change. A person can leave who has the institutional knowledge, they take it with them, and then the next person is starting from scratch with the process, sometimes with the relationships. So consistency and momentum can really suffer. We've talked about relationships and who's at the table and who's making referrals to the teams and who the teams are referring to. But some partners aren't at the table in some communities. So, like some teams have little to no law enforcement support. And so that makes it really difficult to do this community-based work and find their people and make connections. And then sometimes because there isn't coordination from some of those key players, then it's hard to access referrals in a timely manner. There's a delay, and that impacts kind of that motivation window, and we lose the opportunity for people to connect. So the 2024 deflection inventory, we came across, or it pointed to 6 core themes, some of which we've already kind of talked about. There's diversity and implementation. There's sustainability concerns when we talk about infrastructure. Sustainability also means funding for teams because most of them are grant funded. Data collection and training looks different. It happens in lots of different ways at varying frequencies, which makes consistency challenging. But to really drive home this coordination piece, I just want to highlight that relationships are central to success of teams. This doesn't happen without coordination of care. Teams need relationships with entities that can help them reach people who are at risk, such as first responders, and they need relationships with treatment providers and recovery supports and other community supports so that they can be responsive once they engage with someone. When someone's ready to go to treatment, we want to be able to make movement before that small window of opportunity closes. And when I say relationships, I don't just mean we have like a resource guide or we know the phone number to the agency. Like, I mean, we know Donna and we have great rapport with her and we have her direct line. Also, innovation is really central to deflection. It's how the field got started in the first place. We continue to see really cool things happening across the state, but all of those have required coordination and connection. And cross-sector coordination isn't just helpful, it's really essential. We know that people with substance use disorders are often touching multiple systems, whether it's a primary care provider or a peer supporter or a psychiatrist, first responder, emergency department staff. Each of these people in that network plays a role in that individual's care, and deflection relies on us weaving those roles together into a shared response for an integrated approach to the complex needs that people present with. So finally, there were some themes that stood out from the inventory that can help identify some practical steps to start or strengthen coordination. And we also developed a quick start tool that I can show you in a couple of seconds that has more detailed information about some of these things. But first, you can designate a leader and use MOUs to define these roles and responsibilities across the partnerships that you build. You can pull resources where you can to expand capacity and sustainability. Braiding funding from multiple agencies is an example of this. It's important to establish your infrastructure so your teams and partners are clear on how they work and that there's consistent communication for efficiency and effectiveness. We talked about multidisciplinary teams and how they bring various strengths and resources. So that's important to think about when you're building your team. And remembering that that interdisciplinary component lays the framework, the natural framework for cross-sector coordination. Training together with your team and close partners on core topics like in the case of deflection, we look at motivational interviewing and harm reduction and trauma-informed care so that you're speaking the same language and you're on the same page. And then data tells your story and can help you improve the work with your partners, the support that you get, etc. So as I mentioned earlier, we have an Echo, which is one of the most powerful offerings for deflection. And we see lots of sectors on that platform. We have law enforcement and other first responders, peers, behavioral health, public health, and they all come together and learn and share and problem solve in real time. You guys are familiar with the Echo model, but we meet the second Thursday of every month at 1 p.m. And like I said, our next sessions will be focused on the 6 pathways of deflection and pre-arrest diversion. So that'll be September 11th. And then I also mentioned that we focus on training and technical assistance and coordination and resource development. So I just wanted to offer a few things that might be of interest to you all. The QR code on the right side is our email distribution list. We usually are sending out a monthly newsletter with resources or tools. And because deflection is multidisciplinary, we include resources from a lot of different spaces and sectors. You guys will have access to the slides, so our website, and then just really want to call attention to our Knowledge Hub. This is where most of our technical assistance tools live. So that quick start guide that I referenced is on the website. We have some technical assistance videos. Recently, we've had a couple that are focused on that cross-sector coordination. We did one on emergency department partnerships, and then one on brain injury and overdose, and thinking about all of the people that might come into contact with someone who has a brain injury after overdose and how to coordinate or be involved in care. So that's all I have. I'm happy to take any questions or hear your thoughts about any of this. My contact information is on the slides. And if you're interested, there are references from the inventory report on here as well.